A few more questions which are coming on the chat, which I'll just post directly to some of the faculty. And perhaps the first one perhaps is to Prof. Bahad and Prof. Razak, and that's about the use of fibrinogen concentrates and prothrombin complex concentrates. That means moving away from human-derived blood products or prepackaged ones, but into more of this recombinant or synthetic products. Do you think we'll be seeing a big move towards that and thus reducing the use of FFP and cryoprecipitate in the future?
Yeah, I think that the concentrate products are fabulous, and they are becoming more and more accessible and more affordable. And the beauty of them is, especially in the secondary phase of resuscitation, when you want to be more targeted based upon some laboratory results after the initial phase of the protocolized approach. They can be more targeted, they're very effective, and the real advantage of them, I think, is their stability, so that they're very useful and very easy to maintain and manage them in an easy fashion. They do not require refrigeration. They're easy to reconstitute, and they're extremely effective and very, as the name would suggest, very concentrated. And fibrinogen, when we do look at the middle to later phases of these exsanguinating patients and their resuscitation, where we tend to get it wrong is in failing to give enough fibrinogen, especially when you don't have the opportunity to give whole blood, which many of us unfortunately don't have easy access to whole blood. It's often the fibrinogen that we fail to provide, which seems to be quite important in recovering the coagulation normalcy that we would like to achieve in these patients. So fibrinogen concentrates especially, I think, are very potentially advantageous, and I think we will see it more and more in the future, as well as plasma concentrates as well.
Thanks a lot, Prof. Perhaps a question for Prof. Bahad. It's about Reboa as well. In low volume centers, do you see Reboa having a role, or do you think it becomes more of a hindrance to actually getting the patient to an area of hemostasis?
I think that it depends on your local resources. Reboa is extremely expensive in its supplies. It's usually locked up. If you want it, you need it there, you need it available. So the answer is, like everything else, if you have it and you're trained to use it, because there is a significant complication rate, then it definitely has a place. I don't think that Reboa is as effective in penetrating injury than stopping the bleeding directly. So I'm giving you a guarded yes. I think if you can, it's like all of the artificial fibrinogen products. If you have the money, it's wonderful. If you haven't, you have to use what is available to you. Tech has the advantage because it'll save you a huge amount of money, yes. Reboa, what do you do next? You put it in, if you leave it blown up for a couple of hours, everything below it, particularly bowel, is dying off. So they're now going through modifications called intermittent Reboa, where you blow it up and take it off, or partial Reboa, where you decrease the perfusion pressure below it. But I still think that the best way of putting it at the moment is when somebody has given you a new hammer, everything looks like a nail.
Quite true there. And Prof. just one more about the last question on Reboa was, do you think it would replace an ED thoracotomy for patients in traumatic cardiac arrest, because especially a zone 1 Reboa?
I think yes is the answer. It does. The two series that we know about is, if you're frightened of an emergency room thoracotomy or don't have the ability to do it, then Reboa may offer an alternative. So that's the first thing. The second is that the Japanese particularly have got excellent results from CPR with Reboa in place for medical cardiac arrest. I'm afraid with hypovolemic cardiac arrest, if you haven't got any blood left, then Reboa is not going to make a huge difference. So a guarded yes, if you're trying to stop below bleeding or if you're trying to preserve the brain. But if you're not doing it, then I don't think now is the opportunity. I'd be interested to see how my colleagues' response is. Dr. Eric particularly. Europe. One last thing which we have done, we had a gentleman who was trapped in a log cutting machine up to his perineum. The machine was 2 tons and it took nearly 2 hours to separate it. And the decision was made to do a hindquarter amputation with him still in the machine. So we put in a Roboa on site, blew it up while the hindquarter amputation was performed, immediately got vascular control and deflated it. So yes, it can save lives. That's all I need to say about it.
Thank you.
Yeah, while we're doing, I could just say that I think Roboa, for us, we use it selectively. It takes a considerable skill set, so it is not as easy as it is often advertised. And so I think, and we've had several cases, especially when the patient is in arrest, when you are initiating management, that I think the thoracotomy still has a role, because in most clinicians' hands at this moment in time, that is a much more rapid procedure to achieve the outflow control from the aorta, which is the goal you're trying to achieve. And so we've had a couple of cases where the operator is struggling to insert the Roboa, especially in younger women where the access is difficult and the vessels are small and the patient is in arrest. And then we convert rapidly to thoracotomy and clamp the aorta. So I would not see them as exclusive. I think they are both skill sets that we need to use in different settings, depending on what you have available to you and what the situation of the patient is.
Thank you. I think that's quite a balanced answer now. Another question for Dr. Scott, and I think we talked about this earlier. In Japan, for example, there is a hybrid emergency room kind of a setup where this hybrid theater is in the emergency room, and that becomes the initial point of landing for patients. Have you had experience with that? Do you see patients going directly to these rooms bypassing the ED as a way forward?
I think we've got slightly different setups and systems in different places, and my understanding of how that works in Japan is that it works quite well. We've looked at the potential for taking patients direct from the pre-hospital environment, and whether there's any value to taking a selected patient group again straight to the hybrid environment. What we found so far is that, I mean, obviously in the pre-hospital setting, the pattern of injury is probably what's most relevant. But even with that information and the patient's physiology, we're probably only hitting about 50% in terms of being able to evaluate whether the patient is going to benefit from that hybrid environment. So I think in most situations, those patients still benefit from landing in the resus room first. Of course, if you've got a resus room where you've got the hybrid capability right in the resus room, that can be a potential advantage just because you're not transporting the patient long distances. But again, it depends on how often it's being used, because then you're often having to bring in expertise from elsewhere, be it interventional radiologists, anesthetists, nursing, to support that hybrid environment. So it depends a lot on volume, and the value to it is variable depending on the environment, I think.
Thank you very much. Perhaps I could invite Prof. Kochi actually to perhaps comment on the Japanese experience here using these hybrid emergency rooms.
In Japan, hybrid resuscitation room is common, so it is very useful to treat a patient at the one place. So we can treat the patient as soon as possible, IVR and operation. So it is a very good system for us.
Thank you, Prof. I have a question here for Prof. Burapan, and that's the use regarding how soon after a hemothorax is developed should we do a CT scan, or should we go to axial imaging? How early on should we do that? in the course of a patient coming in with a hemothorax, with or without a chest drain?
Don't get me started. The CT scan is known in various countries as the donut of death or the tunnel of doom. And I know of no CT scan that has ever stopped bleeding. And I see Scott's going to come in now as well. But the reality is, I don't think that a massively bleeding patient should leave the ED for bleeding reasons unless the bleeding is stopped there or they're stopped in the OR. And I think that unfortunately many young physicians nowadays think that the CT scan is therapeutic. It is. It makes them feel better, not necessarily the patient. So bleeding patient, no CT, stop the bleeding, then get a diagnosis of anywhere else. You need a live patient for a diagnosis. Scott, or would anybody else care to answer that?
I'd comment on that. I think there are different patient subgroups that we're talking about, and the vast majority of really unstable patients, as you've identified, really do benefit from a very quick trip to the operating theater for immediate hemorrhage control. Those aren't the patients that are going to, benefit from imaging. But increasingly, we are taking more and more patients who have been hypotensive and who are supportable in terms of what we're doing with the patient and with the patient, with the operating theater team or the whole caring team in attendance. We do take some of those patients to the CT scanner, and I think that's increasingly happening in lots of environments, and safely so, because it really does benefit us to have that level of information we get from a CT scan to further direct our interventions.
With the caveat that you are one of the fortunate, as we are, people with a CT scanner around 5 meters from the resuscitation bay. And in fact, in some German centers, the resuscitation bay is the CT scanner. You need a 12-meter long room. The gantry sits between 2 beds, and you can scan one side or the other. But for those who have a CT scanner, the further away, the smaller the returns in terms of the risks.
Prof. Rapat, for patients who have stabilized and who do seem to have a retained hemothorax on X-ray, would you advise getting scans first, or do you think there's enough indication to go in without a CT?
I don't think there's enough for that. The reality is, if you've got that sort of injury, there's an awful lot of plumbing in close proximity. So I would generally go for a CT scan if the patient could stand it, because if you've got a big hemothorax, is it actually the busted spleen leaking through the diaphragm, for example? So I think one of the things that I see in many centers is that the CT scans are too restricted. They do a head scan without the neck scan. And I think we've stopped thinking of chest and abdomen. We've started thinking of torso. And in most injuries, I would see a torso scan, which is a chest, abdomen, and pelvis together. The other thing is we routinely use contrast for it. And with our head scans, we also, with blunt injury, emphasize blunt injury, routinely use contrast when we scan the neck. We've seen several patients who have got neck vascular injuries in the presence of blunt head injury. So in penetrating it's different, but in blunt injury and in torso injury, we would routinely use contrast as part of the CT.
I have got a question to Professor Bhopal. Sir, that our greatest potential in saving patients in the traumatic deaths in the pre-hospital setting, the hemorrhage. What's your, how you guide to them in the future practice? How we can address, how we can organize to address this pre-hospital exsanguinating deaths?
I would also defer to my 2 colleagues. Frankly, I think it depends on the country. I think it depends on the distance, both to get them to the patient, and secondly, where are you going to take the patient? I think that The level of training makes a huge difference, because advanced life support paramedics who can intubate, and in South Africa, our critical care paramedics are in fact able to put in C-lines, chest drains, and all of that, and do cricothyroidostomies. That is very different. So I can't answer for a specific country, other than to say there's lots, as a generalization, if it is external bleeding, you can press on it. You can put tourniquets, or you can put blood pressure cuffs on. If it's internal, non-compressible bleeding, the art is to recognize that it's happening and get the heck out of there to a hospital which can do something about it. But I accept that's not always possible. I haven't answered your question fully.
And if I could throw that question over to our other war surgeons here, Commander Fitch, in the pre-hospital setting, for example, right now, what do you see as the interventions that we're doing pharmacologically in the pre-hospital, in terms of pre-hospital blood, TXA, or other agents? What's the US feel on this?
I think, again, as Professor Beaufard pointed out, it depends very much on where you are and how quickly you can get somewhere else. I get concerned sometimes in military settings when we talked about Reboa, and when Reboa started becoming a big deal, and we were seeing what it could do, and there were those who said, well, we should give it to our medics in the field and let them put Reboas into people because then their vital signs will be better, and we have prolonged, transport times. And I think they're missing the piece that Dr. Beauford pointed out, that when you put that zone 1 Reboa up, yes, their vital signs get better, but their bowel all dies. And so if you're not somewhere where a surgeon can take care of the problem that you're trying to bridge to, then you haven't really helped the patient. You've just brought a live brain with a dead body attached to it. So I think it depends on where you are and where you can get. There's good data out of some cities in the United States that gunshot wound victims actually survived better when they were brought to the hospital by the police car or a bystander car rather than the ambulance, right? Because the police don't stop and try to do stuff on the scene. They throw them in the back of the car and drive to the hospital, and they get to the operating room where someone can actually take care of the problem much faster. If you're somewhere where you're rural and farther out, then yes, your pre-hospital care folks, your paramedics need to be able to do more, because there's no way to get there, to get to the hospital quickly. And so I think it's very much a balance of everything you ask pre-hospital to do potentially increases the amount of time you spend in the field. And you have to balance the benefit of that thing they're doing with the risk of it taking longer to get to a hospital and making that transport time actually longer. So it's a very individualized, based on your system, sort of decision and training and capabilities, decision that has to be made by the whole team, with a lot of factors involved.
Thank you. Perhaps just one last question for Prof. Burapat. It's actually regarding the VATS, and you mentioned about VATS for our retained hemothoracis. Now, do you think you need a thoracic surgeon for that, or do you think our everyday general surgeon can use their laparoscopic skills to, in a sense, to do this procedure, especially in the early times before you need decortication?
VATS, well, back in our country, we don't have enough thoracic surgeon to provide that kind of care. So for the skill set for the VAT, most general surgeons who have done laparoscopic surgery can do that, can get training to acquire those skills. It's not that hard.
Thank you. Prof. Talent, similar situation in Philippines as well?
Well, first, I'd like to comment that in the Philippines, pre-hospital care is almost non-existent. That's saying it bluntly. Your best bet is the fastest vehicle that can bring you to the closest center that can treat you. And we all know that, and we accept that. Now, we've tried to work around it already. Now, as to the question was regarding, if you were referring to
doing VATS of video.
Doing VATS, VATS is being done by both general surgeons who've trained in laparoscopy, as well as thoracic surgeons who've trained as well. No, we don't have a common accreditation for it, but we do it in our house, in most big trauma centers in the country.
I agree with Professor Talents. I'm from the Philippines. I'm a neurosurgeon here. and most of the time, the patients arrived at with us that's already exsanguinating, and my part as a neurosurgeon usually comes a little later after they've actually resuscitated these patients. Now, anyway, before you end or you give another question, let me just ask our panelists here if regarding the hypertonic lactate solution, because we usually use a hypertonic lactate solution in resuscitating brain trauma patients. How about, you know, the trauma in general?
Yeah, I can answer. Anyway, if a general polytrauma patient requires resuscitation, we tend to prefer to use blood products and stay away from anything else that's on the market. If it's an isolated head injury and the hemodynamics are otherwise normal, or even the patient's having a Cushingoid type of response, in that setting, when we don't think there's any hemorrhage going on significantly, but it is a significant head injury scenario, and there's evidence of neurologic compromise without hemodynamic compromise, then in that setting, we will use hypertonic solutions as a treatment for the head injury management and the intracranial pressure and neurologic management, not as a resuscitation process, I would say.
Thank you so much, Professor.
All right, and I think I think we have been talking for quite a while now, and we've had a good discussion. So I'm probably going to bring the bit of the discussion period to a close. But perhaps any last words from our faculty from today? And perhaps the final word, Prof. Bofat, if I could ask you if you have any last advice for the general trauma community of the world.
Not final words. I think that the magic of trauma is no two patients are the same. There's no such thing as a final word. One thing that wasn't covered, just to raise it because it's Wednesday, please do not use sodium bicarbonate to deal with the pH. I'm speaking now with my other hat on, like Tarek, we're critical care specialists as well. Do not use sodium bicarbonate to deal with an acidosis in a trauma patient, because it is not primarily the acidosis that's the problem, it's the cause of the acidosis. And if you get the ventilation better and you get the circulation better. But I really wanted to compliment the entire team as part of Asia Trauma Collaboration. This is a unique initiative. You've had just short of 400 throughout a 3-hour session, which has been hugely enjoyable. So on behalf of all of your internationals, thank you for the privilege of taking part, and we look forward to listening in on many more.
Thank you very much, all of you. Maria?
Yeah, I mean, we can probably hear from Professor Scott. Yeah, Mars?
I would just echo what Professor Boffard said. I think it's been a huge privilege for me to engage with this group, and I think obviously the other speakers have been fantastic as well. But the questions and the interaction with the reactors, with the participants who are listening and watching has been fantastic as well. Some really great questions and a great forum for interaction. So thank you again for allowing me to be part of it.
Hey, Raj, you may.
Yeah, I think and Prof. Razak, any final thoughts as well?
Oh, just a big thank you to all the organizers and all of the participants. Really, it's remarkable to see such engagement, and it's a very encouraging to see this much interest and this much honestly just a fabulous community gathering to discuss issues around trauma care. I think it's obviously a huge issue globally speaking. There's a lot of work to do to improve how we manage our communities and improve care and continue to advance the systems that we all try to work in. And it's a tremendous pleasure to share this with all of you here today. So thank you so much for the invitation. It really is a privilege. Thank you, Professor. It's an honor for us. Now,
and finally, Prof. Burapan.
Yes.
Such a privilege. Really enjoyed to be part of the program.
Thank you very much.